Welcome everyone to Radonk's Smart Review. Today we're doing a really critical session on GYN radiation oncology.
That's right.
We're going to focus specifically on probably the most vital part of curative treatment for locally advanced cervical cancer, brachytherapy.
Yeah, absolutely essential. And not just essential, but mandatory.
Exactly. This isn't just, a quick review. We want to dig into the why, the evidence, the rationale, why you simply cannot skip this step if cure is the goal.
It really is the highest yield topic in GYN radon count. It's the one area where trying to swap techniques, well, it carries a real demonstrable survival penalty. We know EBRT, the external beam, usually with chemo. That's a strong start.
Right. It takes care of the bulk disease, the nodes.
But it's only half the job. Brachytherapy, that's the second part, and it's totally non-negotiable for cure.
So our mission today really is to build that case piece by piece. Why does brachytherapy give a survival edge over just using an external beam boost? Why is the clock ticking so fiercely with that overall treatment time, the famous 55, 56-day rule?
And we absolutely have to cover the modern targeting. The image-guided stuff, HR, CTV, IR-CTV. That's completely changed how we do this compared to, say, 20 years ago.
Okay, let's ground this. Let's bring back our case, Ms. Jackson. 60 years old. Stage 3 C1R disease. She's done great, finished her pelvic chemo RT. Now she's ready for the boost.
And here comes the question we always get. She's tired. The team might be thinking about logistics. Hey, we have this amazing SBRT machine or fancy IMRT. Can't we just, use that to finish things off? Seems quicker, maybe easier on her.
It's the perfect question because it hits the core issue. The difference between what seems convenient and what actually cures is massive here.
Yeah.
Our job today is to give you the solid, evidence-based reasoning to explain confidently why swapping out brachytherapy for SBRT or IMRT for Mrs. Jackson is linked to worse survival. Period. Hashtag why brachytherapy is mandatory. The curative engine. Okay, let's start right at the beginning. The physics, because everything else flows from this. Why can't even the fanciest external beam machine match what brachytherapy does for that central tumor?
It boils down to physics 101, really, the inverse square law.
Yeah.
It's all about where you put the radiation source. So think of the tumor or what's left of it after EBRT as like the wick of a candle.
Okay.
Brachytherapy puts the source, the actual radioactive material of flame, right inside or smack up against that wick, inside the cervix. The dose right there is incredibly high. We're talking ablative doses.
Just cooking the tumor from the inside out.
Exactly.
Yeah.
Now think about that inverse square law. What happens to the dose just a tiny distance away?
It drops off incredibly fast, like it's squared with distance.
Precisely. Dose falls off with the square of the distance. So you move just, say, 2 centimeters away, the dose plummets to 1/4. You move 3 centimeters, it's 1/9. This incredibly steep dose gradient.
That cliff edge.
Yeah, the sharp cliff edge is physically impossible to create coming from the outside with external beams. The tumor core gets that massive dose, but the bladder wall, the rectal wall, just millimeters away, they get a dramatically lower, much more tolerable dose.
That's the magic trick, isn't it? That rapid fall off protecting the normal tissues. So if we ditch brachytherapy and say, okay, let's use SBRT or IMRT, we're firing beams from outside. What happens when we try to crank up that external dose high enough to sterilize the middle of the cervix? What happens to the rectum and bladder then?
Well, you hit a wall, a physical limitation. Even with super precise techniques like VMAT or SBRT, you've got beam penumbra, you've got scatter, you've got dose blurring as the beams enter and exit. To get that central dose high enough, we're talking equivalent doses, EQD2, of maybe 85, 90 grays or more, to really kill everything. You just can't avoid dragging huge amounts of dose into those immediately adjacent organs.
You lose the gradient.
You completely lose that tight protective gradient, so you're stuck. Either you underdose the tumor center to save the rectum and bladder, risking recurrence,
Which defeats the whole purpose.
or you push the dose high enough for the tumor and you end up blasting the rectum and bladder with unacceptable doses, leading to potentially catastrophic late side effects, fistulas, necrosis, things we try desperately to avoid.
And this isn't just a theory from a physics textbook. This plays out in the real world, right? Where
Right.
people have actually tried to substitute external boosts.
Oh, absolutely. The clinical evidence here is overwhelming. It's really not debated anymore among experts. We look at the big population databases, SEER, the National Cancer Database, NCDB in the U.S. These are huge registries.
Yeah, thousands and thousands of patients.
Exactly. And they've compared outcomes for women with locally advanced cervical cancer. Group 1 got the standard chemo RT plus a brachytherapy boost. Group 2 got chemo RT plus some kind of external beam boost like IMRT or maybe early attempts at SBRT.
And the results? What's the consistent finding?
It's incredibly consistent across multiple studies, multiple analyses. The patients who got the brachytherapy boost had significantly better disease-specific survival and overall survival, better cure rates, living longer.
And that's even after they adjust for other factors like stage, age, tumor size.
Yes, even after complex statistical adjustments to account for all those potential confounding factors, the survival benefit for brachytherapy holds true. Swapping it out for an external beam boost is consistently associated with worse outcomes, inferior survival.
That's huge. We're not just saying, oh, maybe slightly less local control. We're talking about a difference in overall survival. That's the bottom line in oncology.
It absolutely is.
So this leads directly to our first really critical clinical pearl, something you just have to internalize.
Yeah. Pearl number 1, and probably this important. Brachytherapy is mandatory for curative intent in locally advanced cervical cancer. Full stop. External beam boosts, IMRT, SBRT, whatever, they're not equivalent. They're associated with worse survival in large data sets.
So when should they ever be considered?
Only in truly exceptional circumstances where placing the brachytherapy applicator is physically impossible. Maybe extreme vaginal stenosis that can't be dilated, or perhaps a patient who genuinely cannot tolerate the anesthesia required, but those are rare cases. Convenience is not an indication.
Right. This is vital for board exams, too, where they might present a tempting scenario for SBRT.
Definitely. They'll test this. You have to stick to the standard of care.
Okay, let's bring it back to Mrs. Jackson. She's sitting in front of you. She's heard SBRT might be an option, maybe easier. How do you counsel her using this evidence?
You have to be direct but compassionate. You say, Mrs. Jackson, I understand you've been through a lot, and SBRT is an amazing technology for many cancers. But for your specific cancer, cervical cancer, all the best evidence we have from studying tens of thousands of women shows that the highest chance of cure comes from putting the radiation source right inside, using brachytherapy, that unique physics advantage we talked about.
And you mentioned the survival difference.
You have to. The data shows that using SBRT instead is linked with a lower chance of long-term survival. Our goal here is cure, and to give you the absolute best shot at that, brachytherapy is the required next step. It's the standard of care for a reason. It makes the decision clear. Okay, so if the physics tells us what dose to give and where, the radiobiology tells us when we need to give it. This brings us to the second absolutely critical factor, overall treatment time, OTT.
Right. The famous time crunch in cervical cancer. Define OTT for us again, precisely. And why is this clock ticking so much faster here compared to, say, prostate cancer?
Okay, precision is key here. OTT starts the clock on day 1, the very first fraction of external beam radiation. And the clock stops only after the last fraction of brachytherapy is delivered.
Got it. First EBRT to last brachy.
Exactly. And the reason it's so critical in cervical cancer is a phenomenon called accelerated repopulation. Cervical cancer cells, especially after they start getting hit with radiation, can kick into high gear. The surviving cells get a signal, essentially, to divide faster.
It's like the tumor is fighting back against the treatment, trying to regrow faster than you can kill it.
That's a great way to put it. It's a biological counterattack. And classic studies, going way back, actually measured this. They found that if the treatment drags on too long, the speed of this repopulation increases so much that the new cells being born start to cancel out the cells being killed by the later radiation fractions.
You end up just treading water, basically, not making progress.
Precisely. You lose the therapeutic game. And this is what led to that hard and fast rule that everyone learned.
The 55 to 56-day rule.
That's the one. The entire course, EBRT plus all the brachytherapy fractions, absolutely must be completed within 55 to 56 days. There's no wiggle room on this if you want the best outcome.
And missing that deadline isn't just a theoretical problem. There's a real measurable penalty, right? What are the numbers residents need to know for that?
Yeah, the penalty is quantifiable and clinically significant. The older series, which are still very relevant biologically, documented this clearly. For every single day you go beyond that 55, 56-day window, you see a drop in effectiveness.
How much of a drop?
The commonly quoted figures, and these are good numbers to remember, are roughly a 0.7% decrease in pelvic control.
0.7%.
And about a 0.6% decrease in overall survival per day.
Okay, 0.7% per day sounds small, maybe. But let's think about Mrs. Jackson. Say there's a scheduling snafu, or the machine goes down for a week and her treatment gets pushed out by, say, 10 days.
Right.
That's 10 days times 0.7%. That's a 7% lower chance of controlling the cancer in her pelvis. just from a 10-day delay. That's huge.
It's absolutely huge. It really highlights why seamless coordination between the external beam and brachytherapy teams is non-negotiable. You can't afford delays.
So what's the practical scheduling advice? When should brachytherapy typically start?
You need to plan ahead from day one of EBRT. The standard guidance is to initiate the first brachytherapy insertion sometime during week 4, week 5 of the external beam course.
While EBRT is still ongoing.
Yes, concurrently. And often, especially with HDR brachytherapy, you'll need to schedule the fractions efficiently, maybe twice a week, to ensure you deliver the full prescribed brachytherapy dose and still finish everything comfortably under that 56-day wire. That clock is ticking from the moment that first EBRT beam turns on.
This brings us to our second clinical pearl then. It's not about the what, but the when.
Exactly. Pearl number 2 is all about the clock. You must aim to complete the entire course, EBRT plus brachytherapy, within 55 to 56 days. If logistics get tight, if you're pushing up against that deadline, you need to do whatever it takes, work late, run sessions on a Saturday if necessary, to avoid that steep biological penalty. Don't let the schedule compromise the cure. #modern techniques and target definitions.
All right, let's pivot now to the brachytherapy technique itself, because it's evolved dramatically. For decades, the standard was, well, pretty basic 2D planning based on X-rays, looking at bony landmarks, and targeting a theoretical spot called point A.
Right. Point A was kind of a geometric concept, 2 centimeters up and 2 centimeters over from the cervical ass. It was the best guess we had with 2D imaging.
But the modern era, really pushed forward by groups like GYN, Estro, and the big Embrace trials, is all about volumetric, image-guided adaptive brachytherapy, usually using MRI, sometimes CT. What drove that massive shift away from 2D and point A?
The fundamental problem with the 2D point A approach was the risk of a geographic miss. Point A is just a point in space. It doesn't always line up perfectly with where the actual residual tumor is, especially if you have a large tumor, an asymmetric one, or one that didn't shrink much with the initial chemo-RT.
So you could be delivering a high dose to point A, but maybe missing part of the actual cancer.
Exactly. Or unnecessarily overdosing normal tissue. The move to volumetric guidance, especially MRI, was driven by the need to actually see the remaining tumor at the time of each brachytherapy procedure. We needed to conform the dose to the real target, not just the theoretical point.
This led to the GYN-Istro target definitions, which are now standard language. You absolutely have to know these. Let's break them down, starting with the most critical one. The high-risk clinical target volume, or HRCTV.
Right, the HRCTV. This is your primary target for the high-dose boost. Its definition is precise. It includes the entire cervix, plus all residual macroscopic visible disease present at the time you do the brachytherapy planning scan.
So it's the cervix itself, plus whatever lump or bump of tumor is still visible after the initial chemo-RT.
Correct. And the best way to see this is typically on T2-weighted MRI. T2 imaging gives great contrast between tumor, which often sees bright or high signal on T2, and the surrounding normal tissues or treatment-related edema.
Okay, so HRCTV is the main bullseye we need to hit hard. Why do we also need a second volume, the intermediate risk clinical target volume, or IRCTV?
Good question. The IRCTV accounts for the fact that cancer cells might exist microscopically in areas where the tumor used to be, even if it shrank significantly with the initial treatment. We need to cover the area initial involvement to clean up any potential microscopic leftovers.
So it's about treating the microscopic disease risk.
Exactly. The IRCTV definition is basically the HRCTV, the current cervix plus visible tumor, plus a margin that accounts for the tumor's initial extent before any treatment started.
Let's use Mrs. Jackson. Say her tumor was initially 5 centimeters wide, invading the parametrium. After chemo-RT, maybe it shrinks down to just 2 centimeters within the cervix. The HRCTV would be that remaining 2 centimeters plus the whole cervix. What about the IRCTV?
The IRCTV would encompass that HRCTV, but it would also include a volume representing where that initial 5-centimeter tumor spread, including perhaps the medial parametria, to ensure we're treating the zone where microscopic cells might still be lurking from the original larger tumor.
Got it. So 2 targets, HRCTV for the definite visible stuff needing the highest dose, and IRCTV for the at-risk zone needing a moderate but still therapeutic dose.
Precisely. The dose to the IRCTV is lower than the HRCTV dose, but it's enough to handle microscopic disease. The HRCTV gets that full ablative dose needed for cure.
Okay, now let's talk numbers. We always hear doses discussed in terms of EQD2, the equivalent dose in 2 gray fractions. Why do we need this conversion?
It's because brachytherapy, especially High dose rate, HDR, delivers radiation in a few large fractions, maybe 5 to 7 gray per fraction, compared to the small, daily 1.8 or 2 gray fractions used in external beam. EQD2 allows us to convert the biological effect of these different fractionation schemes into a common language using radiobiological models.
And the key ingredient in that conversion model is the alpha-beta ratio, right? Which differs for tumor and normal tissues.
Absolutely critical. The alpha-beta ratio reflects how sensitive a tissue is to the size of the radiation fraction. Tumors, especially squamous cell carcinomas like most cervical cancers, generally have a high alpha-beta ratio, typically assumed to be around 10 gray.
Meaning they're less sensitive to fraction size, more affected by total dose.
Correct. Whereas the late-responding normal tissues, the bladder, the rectum, the bowel, have a low alpha-beta ratio, usually assumed to be around 3 gray.
So they are very sensitive to high doses per fraction.
Exactly. And this difference, alpha-beta 10 for tumor, alpha-beta 3 for normal tissues, is the therapeutic window that high-dose rate brachytherapy perfectly exploits.
How so?
By giving those few large brachytherapy fractions, we maximize the damage to the tumor, alpha-beta 10, while relatively sparing the late effects in the normal tissues, alpha-beta 3, provided we keep the absolute dose to those normal tissues low using that steep physical dose gradient we talked about earlier.
It's leveraging both the physics and the biology. Very clever.
Really is.
Okay, let's nail down the specific EQD2 numbers we're aiming for in Mrs. Jackson's plan. What's the target dose for the HRCTV?
For the HRCTV, the goal is cure. We need to ensure that at least 90% of that volume, the D90, receives an EQD2 of greater than or equal to 85 gray, ideally aiming for 90 gray if possible while respecting constraints. Falling below 85 gray significantly increases the risk of local recurrence.
85 to 90 gray, EQD2 D90 to the HRCTV. Got it. Now the flip side. The critical safety limits for the organs at risk, usually reported as the DDCC.
Safety first. The DDCC, which represents the maximum dose to a small 2 cubic centimeter volume of the organ, must be kept strictly below certain thresholds. For the bladder, the limit is less than or equal to 90 gray EQD2, using alpha-beta 3.
Okay, under 90 for bladder DTCC.
And for the rectum and sigmoid colon, the limit is even tighter, less than or equal to 75 gray EQD2, again alpha-beta 3. Bowel loops sometimes get included here too.
Under 75 gray for rectum and sigmoid D2CC. These are hard limits.
Absolute hard limits. Exceeding these significantly increases the risk of severe late complications like fistulas or chronic bleeding. Modern image-guided brachytherapy is all about maximizing the HRCTV dose while rigorously respecting these OAR constraints.
This gives us our third clinical pearl focused on the how of modern planning.
Yes, pearl number 3, know your volumes, know your numbers. HRTTV is cervix plus residual gross tumor, needing 8590 GAQD2D90. IRCTV covers the initial extent for microscopic disease. And critically, obey the OAR D2CC limits, 90G for bladder, E05D2 rectum sigmoid. These are the operational goals of image-guided adaptive brachytherapy.
So, back to Mrs. Jackson. Before her first brachytherapy session, the essential step is getting a high-quality planning MRI, ideally T2 weighted.
Absolutely.
Then meticulously contour the HRCTV and IRCTV based on that MRI and her initial staging information. Then plan the brachytherapy sources to hit that 85-90 HRCTV goal while keeping the bladder and rectum doses firmly below 90 and 75 GI respectively. And you might adapt this plan slightly for each fraction based on anatomy changes.
That's adaptive radiotherapy in action. Precisely. Hashtag evidence and toxicity management. Now, this whole paradigm shift from 2D point A to 3D MRI-guided adaptive brachytherapy targeting HRCTV wasn't just a good idea on paper. It was rigorously tested and proven in a massive international effort.
You're talking about the EMBRACE studies.
Primarily EMBRACE-I. This was a huge prospective multi-institutional cohort study. It basically standardized and implemented this exact approach, MRI-guided adaptive brachytherapy combined with chemo-RT across numerous centers, mostly in Europe.
So what did EMBRACE-I show? Why is it considered such foundational evidence?
It provided the definitive proof of concept. It showed that when you systematically apply these principles, use MRI guidance, carefully define HRCTV and IRCTV, push the HRCTV dose to those equals 85 GC levels, and strictly respect the OAR constraints we just discussed, the outcomes are dramatically better than what was seen historically with 2D techniques.
Okay, give us the headline results. What kind of numbers did they achieve?
The results were genuinely practice-changing. EMBRACE. I reported a 5-year local control rate, meaning cancer, controlled within the cervix and parametria of around 92%.
92% local control in locally advanced cervical cancer. That's phenomenal.
It really is. Pelvic control, including nodes, was also very high, around 87%, and overall survival at 5 years was reported around 74% in this cohort, which included many patients with advanced stages.
That 92% local control figure really underscores the power of getting that high conformal dose right into the HRCTV. That's the key metric proving the brachytherapy boost works.
Absolutely. But equally important was the toxicity side of the equation. The whole strategy only works if it's safe.
Right. Did they see acceptable side effects?
Yes. The study showed that these excellent cure rates were achieved with what were considered acceptable, moderate rates of late grade 3 or higher toxicity to the bladder or bowel. This was the crucial validation. High cure rates with manageable long-term side effects, thanks to respecting those OAR dose constraints enabled by image guidance.
Okay, so the trial data is compelling. Let's translate that to Mrs. Jackson in the clinic. She needs to understand what to expect during and after treatment. Let's walk through the potential toxicities and how we manage them, maybe chronologically.
Good idea. Let's start right around the brachytherapy procedure itself. What are the acute peri-procedural issues?
Yeah, what happens during or immediately after the insertion?
It's common for patients to experience cramping, sometimes significant, during the applicator placement. Some minor vaginal bleeding or spotting is also normal. Urinary discomfort or urgency can happen due to the proximity to the bladder. And of course, there are the effects of the anesthesia or sedation needed.
What are we doing proactively to minimize risks during the procedure?
Standard safety protocols are essential. Gentle sounding and dilation of the cervix is key to avoid trauma. Using ultrasound guidance, especially for tricky insertions, helps confirm correct applicator placement and avoid perforating the uterus, which is a rare but serious risk. Strict sterile technique is vital to prevent infection.
And post-procedure?
Careful monitoring and recovery for pain, bleeding, and ensuring the patient can void properly is important, as urinary retention can sometimes occur temporarily.
Okay, moving on. What about the side effects during the weeks where she's getting both the end of EBRT, weekly chemo, and the brachytherapy fractions? That sounds like a tough period.
It definitely can be. This is when the cumulative effects really hit. Fatigue is almost universal and can be quite profound. Nausea, particularly on the days around the weekly cisplatin, is common. Diarrhea from the pelvic radiation often peaks during this time.
What else?
Bladder irritation, so cystitis, or urethral irritation causing dysuria, painful urination, is frequent. And increased vaginal discharge is also expected.
How do we manage this cluster of symptoms?
It's largely supportive care, but it needs to be proactive. Good anti-nausea medications given before the cisplatin, encouraging excellent hydration, starting anti-diarrheal medicine like loperamide early at the first sign of loose stools, not waiting for it to get severe. For the bladder symptoms, sometimes a short course of phenazopyridine can help numb the discomfort, though it turns urine orange.
Good supportive care is key to getting them through it. Now, let's talk long-term. The late toxicities. These can really impact quality of life years down the road. What are the main concerns?
The most common long-term issues relate to vaginal health. Radiation causes fibrosis, leading to vaginal dryness, shortening, and stenosis and narrowing of the vagina. This requires lifelong attention.
What else?
Chronic inflammation of the rectum, proctitis, or bladder cystitis can occur, causing persistent bleeding, urgency, or pain. And while much less common with modern techniques, very serious complications like fistula, an abnormal connection between organs like rectum and vagina, or radiation-induced pelvic bone fractures can still rarely happen.
Let's focus on the vaginal changes first, as they're so common. What's the essential management strategy we need to teach Mrs. Jackson?
Vaginal dilator use. This is absolutely crucial. Patients need detailed instruction and consistent encouragement. She should start using appropriately sized vaginal dilators about 4 to 8 weeks after finishing all radiation.
And how often? For how long?
The recommendation is usually several times a week, maybe 3-5 times, for about 5-10 minutes each time. And this isn't just for a few months. It's really a lifelong maintenance strategy to prevent irreversible stenosis and maintain sexual function if desired. Patient education and adherence here are paramount.
Okay. What about managing chronic proctitis or cystitis if it develops?
Initial steps often involve dietary changes, like avoiding trigger foods. Topical treatments like steroid or mesalamine suppositories can sometimes help for proctitis. For more persistent symptoms, there are other approaches.
Such as?
There's some evidence for using oral medications like pentoxifylline combined with vitamin E, which may help improve microvascular blood flow. And for severe refractory cases of bleeding or pain from radiation cystitis or proctitis, early referral for hyperbaric oxygen therapy, HBO, should definitely be considered.
HBO can make a real difference in some tough cases.
It can, by promoting healing in those radiation-damaged tissues. But the most important point, really, is that by using modern image-guided adaptive brachytherapy and strictly adhering to those OAR constraints, especially the 75 GYN limit for the rectum, the incidence of these severe late toxicities has been dramatically reduced compared to the older 2D era. Prevention through better planning is key. #board review and clinical pearls integration. Okay, we've hit a lot of ground to the physics, the timing, the targets, the evidence, the side effects. Let's boil this down to the 3 absolutely essential clinical pearls you need to walk away with.
Let's recap. Curl number 1.
Brachytherapy is mandatory for cure. Physics says so, inverse square law, and the big population databases, SEER and CDB, confirm it with survival data. External beam boosts like SBRT are linked to worse survival. Don't substitute unless truly impossible.
Pearl number 2.
The clock is ticking. Overall treatment time, OTT, must be less than or equal to 56 days from first EBRT to last brachytherapy. Remember the penalty, roughly 0.7% loss of pelvic control per day of delay due to accelerated repopulation. Schedule aggressively.
And the third pearl, focusing on modern technique.
Know your G-estro targets and doses. HRCTV is the entire cervix, plus visible residual tumor at time of brachy gets 8590 GEQ-D2-D90. IRCTV covers initial extent for microscopic risk. Respect OAR limits. 90G batter GDCC equals 75 Jake rectum sigmoid D2CC. That's the recipe for image-guided success.
Perfect. Let's lock this in with some board-style review questions. Let's test these concepts.
Sounds good. Case 1. You have a 58-year-old woman, stage IIB cervical cancer. She finishes chemo-RT. The referring medical oncologist suggests using an SBRT boost instead of brachytherapy, mainly for patient convenience and quicker completion. Based on level 1 type evidence and large database analyses, what's your recommendation?
Okay, options are: A, SBRT provides equivalent local control, so it's acceptable. B, SBRT is actually superior if the residual tumor is large, say 4 centimeters. C,
Right.
population data consistently show external beam boosts, including SBRT, are associated with inferior overall survival compared to brachytherapy. Therefore, proceed with standard brachytherapy. Or D, SBRT is acceptable only if you guarantee the total OTT stays under 56 days.
What's the answer?
It has to be C. The survival data from SEER and NCDB is the trump card here. Convenience doesn't outweigh a potential survival difference. Brachytherapy remains the standard for cure.
Correct. You have to prioritize the evidence on survival.
Case 2. Thinking about overall treatment time. What is the approximate penalty in pelvic control cited in classic radiobiology studies for each day of treatment prolongation beyond the target of about 56 days?
Options A, 0.1%, B, 0.7%, C, 2.5%, D, 5.0%.
That number we discussed, it's B, 0.7% per day loss of pelvic control, and about 0.6% for survival. Small daily number, big cumulative impact.
Exactly right. You need to know that approximate figure. Okay, case 3. According to the GEC ESTRA guidelines, how is the high-risk clinical target volume, HRCTV, for cervical cancer brachytherapy best defined?
Options: A, the entire uterus plus both parametria. B, the gross tumor volume, GTV, seen at initial diagnosis plus a 1 centimeter margin. C, the entire cervix plus all residual macroscopic disease identified at the time of brachytherapy planning. Or D, only the residual gross tumor itself, excluding the non-involved parts of the cervix.
The correct definition.
It's C. The entire cervix is always included, plus any visible tumor remaining at the time you do the brachytherapy.
Perfect. HRCTV equals cervix plus residual gross disease at time of brachy.
Oh.
Last one, case 4. The landmark Embrace-I trial validated the effectiveness of MRI-guided adaptive brachytherapy. Approximately what 5-year local control rate did this trial report?
Options: A, 65%, B, 74%, C, 82%, D, 92%.
And the impressive result was?
D, about 92%. That really set the benchmark for what's achievable with modern techniques.
Excellent. That highlights the success of the whole approach. #tag outro.
So wrapping this up, we've really established today that brachytherapy isn't just an add-on, it's the core curative engine for locally advanced cervical cancer. The physics gives it an unbeatable advantage.
An advantage confirmed by real-world survival data showing inferiority of external beam boosts. We've hammered home the urgency of that 55 to 56-day treatment window.
And detailed the critical modern GE estro targets, HRCTV and IRCTV, and the dose goals that trials like Embrace I proved can lead to outstanding local control.
Yeah, and maybe one final thought is how it achieves that. Modern image-guided adaptive techniques fundamentally let us leverage that alpha-beta difference. We can safely push the dose super high in the tumor, the HRCTV, where alpha-beta is high.
While meticulously respecting those tight constraints on the rectum and bladder, where alpha-beta is low, minimizing those severe late toxicities, it's targeted, personalized radiation at its best.
That really is the modern standard of care.
Absolutely. For more practice, including mock oral boards, head over to radoncSmartlearn.com.
That's radonsmartlearn.com.
And be sure to subscribe to Radon Smart Review. In our next session on this topic, we'll get practical. We'll dive into applicator choices, planning steps, contouring tips, and dose optimization.
Looking forward to it. Thanks for tuning in, everyone.
Thanks for listening.